All right, so we're heading into our last session, and it's my pleasure to introduce our moderator for the last session. Dr. Catherine Eppes is a good friend of mine. She is also the co-chair for the Obstetric Committee of the TCHMB. She's a maternal fetal medicine physician at Baylor College of Medicine, where she serves as chief of obstetrics at Ben Taub Hospital, and she had a CMS visit today. So she's very glad that's over with. All went well. Dr. Eppes is at Baylor College of Medicine, and she received her dual degrees in microbiology and psychology from the University of Texas at Austin. She received her MD at UT Health San Antonio. She did a residency at Johns Hopkins. Her fellowship and Master's of Public Health degree were received at Northwestern University. Her primary areas of focus are quality and safety in infectious diseases and pregnancy. Recently, she's focused on Zika and pregnancy, including numerous collaborations at the CDC, ACOG, Texas Medical Association, and throughout the state. She currently serves as ACOG District 11, Texas Quality and Patient Safety and Quality Chair, and she serves on the Executive Committee currently as the Data Subcommittee Co-Chair, and we previously served together as the Data Subcommittee Co-Chairs as well. And she's also on the Texas Fetal Infant Morbidity Review for Syphilis and HIV in Pregnancy, and she has several grants from the CDC for infectious diseases in pregnancy. So welcome, Dr. Eppes.
And I was going to ask Dr. Cleveland to come up. So today's been a really interesting day, and we've talked a lot about all of the different things going on in our state for maternal and child health. I think one of the topics we haven't yet talked a lot about is the maternal deaths related to drug overdose, which we know is certainly a problem in our state, but definitely one we have to look at really differently. So many of the bundles we've looked at are hospital-based, and clearly addressing substance use won't cover that. So our last panel of the day is going to be talking about community partnerships to support families recovering from opioid use disorder. And I'm going to admit I'm using panel lightly because Dr. Cleveland originally was one of three, but we're also in the middle of flu, so both of her colleagues are not able to make it today because of that. So with that, I'm going to introduce her, but I'm also going to introduce her collaborators, which she asked me to do, which I think is just really meaningful because they're people she's worked with a lot and have obviously contributed and are part of her slides. So Dr. Lisa Cleveland is a pediatric nurse practitioner and a tenured associate professor at UT Health San Antonio School of Nursing. And her research with mother-infant dyads impacted by opioid use disorder has contributed to the changes in clinical practice and improved outcomes. The Recovery Residence, Casa Mia, is a collaborative partnership between the School of Nursing and the nonprofit Crosspoint. And Casa Mia provides safe, supportive housing for pregnant and parenting women with opioid use disorder, where they can recover with their children. So she also has a number of different grants and is involved with a number of different programs, all surrounding substance use disorder and its impact on overdose deaths and families. And so we're really privileged to have her here to speak today. Her two partners who weren't able to make it today were Courtois and Lisa Ramirez. So B is the licensed chemical dependency counselor with a Master of Science in Social Work and has done a lot of work also in the field of substance abuse treatment. And Lisa Ramirez is the state opioid response director. And so this panel, even if it's a panel of one today, has a lot of experience with opioid use disorder. And with that, I'm going to turn it over to you. Are you able to put up her slides?
This afternoon just keeps getting better. Is there a... Yep, oh, perfect. Well, good afternoon. I'm actually really thrilled to be here, even though I am a panel of one, which is extremely awkward. But I'm going to try to do justice to my partners who were not able to be here today, both of them down with the flu today, because they have been incredibly instrumental in the work that we've been doing in Bexar County, and without their support and their input, I don't think we'd be nearly where we are today. So this was going to be very informal, and I was hoping it was going to be a conversation. I think it still can be, if you all would be willing to play along with me a little bit. So, if you have an idea or you want to talk about something that's happening in your community that's really great, or you have a question, please don't hesitate to interrupt me. So today, I will be discussing the formation of multi-sector community partnerships to improve outcomes for families recovering from opioid use disorder. And these truly are multi-sector, involving multiple different agencies and as well as some nonprofits and faith-based organizations. We'll describe the essential components of successful multi-sector community partnerships. And I do want to share some lessons learned. So if I forget to do that, please remind me, because I have a lot of lessons learned. We've made a lot of mistakes. Fortunately, none of them have been things that couldn't be corrected, but I would be happy to share those with you. So some of you may or may not know, but Bexar County, which is San Antonio and the surrounding area, has been particularly hard hit by the opioid crisis. We have about a third of all reported cases of neonatal abstinence syndrome, or now more commonly being called newborn opioid withdrawal syndrome. So we have consistently had the highest rate in the state since the state began tracking this data. We have about a third of all cases. So to kind of put that into perspective, Bexar County, San Antonio typically has about the same number as Dallas, Fort Worth, and Houston combined. So this problem has really impacted our communities and the families who live there. People ask me all the time why, and I don't know that anybody can truly answer that question. A lot of folks speculate about it's our location, our proximity to the border, perhaps our interstate system that kind of lends itself to drug trafficking. I don't know that anybody can truly answer that question. I know I can't. So I just know that it is a problem in our community, impacting about 300 to 400 families in the San Antonio area every year. And obviously, this is a very costly condition, correct? And I say costly, we talked a little bit about value-based care. It's costly in many ways. It's costly in the sense that it takes a lot of our healthcare resources, but it's also very costly to our families. Early separation of mothers and children and families is probably, I believe, something that we're not going to truly appreciate the impact of for several decades to come. As a result of the current U.S. opioid crisis, there's been a 10% increase in the number of children entering the foster care system nationwide. That's after decades of steady decline. Some states have seen a 50% increase. So in states like West Virginia, Ohio, where they've really been impacted, think about that. About 20 years from now, maybe not even 20 years from now, that is going to have a huge impact on the children of our nation. And so because this is really impacting our community, we took on kind of a community approach, and it sort of happened in waves. And I would say that it kind of happened through just getting to know folks. So I think B. Courtois was probably one of the first people I knew who was really passionate about this topic. Again, she's with the Center for Healthcare Services, and back in 2007, B applied for and was awarded as a Substance Abuse and Mental Health Services Administration grant, or SAMHSA, a 5-year grant to begin a program that is now called the Mommies Program. Has anybody heard of the Mommies Program? It's a beautiful program, and B tells the story so much better than I do, but I'll try. So she kind of started small, and then as the program rolled out, she added on more resources, so things like childcare and transportation that the women were lacking, to really make this robust wraparound program, which has been really, really successful. And so I was working with B on some other things and learned about this program, and that's kind of when we met Lisa Ramirez. She was with DSHS at the time, was really interested in this program, and wow, how do we disseminate this program? How do we package it and disseminate it statewide? And how many of you know Lisa Ramirez? Once she gets an idea in her head, it's going to happen, right? So she came to my team and asked, would we be willing to sort of pull together all of these key components of the Mommy's program into what she was calling a toolkit? I had no idea what she meant by that at the moment, but we figured it out, and we did. We developed this toolkit, which needs to be updated. It was developed in 2015. And then we did go out statewide and do some trainings with other counties that are also experiencing high numbers of neonatal abstinence syndrome. And I think last time I heard there are now like 11 or 12 other Mommy's programs statewide, which is really, really great. So with the Mommy's program, following that, I've submitted another SAMHSA grant, and actually, no, I think it was state-funded initially. She's got a SAMHSA grant now to establish an inpatient residential treatment facility for women and children, and so that was the first one in our community. We are also now, this School of Nursing is also now taking over the NAS Symposium. That was another thing that sort of came out of this legislation that was focused on NAS. Has anybody been to the NAS Symposium? I highly recommend it. We took over the contract about a year ago. Poor Karen Palumbo was working a full-time job and putting on a symposium. I don't know how she did that. But so now our Department of Lifelong Learning has taken that over. It seems to be getting bigger each year. This year it will be in Houston at the end of June. So if you want to go to the UT Health School of Nursing website, check it out. We're bringing in Matthew Grossman this year as our keynote speaker. Does anybody know about Matthew Grossman's Eat, Sleep, and Console? He's really remarkable. I got to meet him. I presented with him last summer in New York, and the only reason I agreed to do it was because I knew he was going to be co-presenting and I wanted to meet him. Really, really phenomenal. He's a general pediatrician and has a very different approach to caring for infants who are experiencing withdrawal. So I really encourage you to check that out. Lisa has also been very instrumental in some of the research my team is currently conducting, which I think is novel. I don't know that most state health departments are funding research, but I really commend her for her foresight and knowing that that's important. And then I'll talk a little bit about some of the program development we have going on. So just briefly, because I know you're not here to hear about research, but I do want to talk a little bit about some of the projects that the state has funded. Our first project was a small pilot at University Hospital in their NICU to look at the non-pharmacologic intervention of skin-to-skin or kangaroo mother-infant care. As you probably know, when it comes to neonatal abstinence syndrome, we kind of have these two kinds of management. The first is supposed to be non-pharmacologic interventions, so things like skin-to-skin care, breastfeeding, swaddling, things that I don't know that we've really tested and really have built the evidence for. We oftentimes are pretty quick to go to our second line of management, which is medication. And so we really wanted to see if kangaroo mother care was effective in relieving some of the symptoms these newborns were experiencing. And so this is one of our mom-baby dyads who participated. This is Hannah and Margot, and I love this picture because this is not the typical image that comes to mind when we think of NAS, right? We talk, usually, in the newspaper, you see a baby with NAS and usually beet red and screaming, right? Well, what we found is when we put these babies skin to skin, they went to sleep pretty quickly and they stayed asleep until they were disturbed. So in a follow-up study that we're working on now, we're looking at babies that are a little bit older, so at about 6 months. We are using a stress experiment and recording interactions between mom and baby, and also looking at some biological markers, really exploring that maternal-infant interaction and the impact that has on later development. And then we mentioned maternal mortality. Another project that we've been working on is the MOMS Project. In Texas, the leading cause of maternal mortality, and when we say that, we mean during pregnancy or the year that follows, the leading cause is overdose. That was first discovered back in, I think, 2016, we really thought that this was a Texas problem. And so Lisa Ramirez came to my team and said, hey, would you all do some work around this and try to figure out what's going on? And so we spent 2 years doing focus groups throughout Texas. We are now publishing those findings, looking at really the context of these deaths. And with that data, we are now working on an instrument and pilot testing that as a brief screening instrument that may be able to identify women who are at risk for both relapse and overdose, because we know oftentimes relapse is what led up to the overdose, right? Once somebody's tolerance has decreased, they're really at risk for overdose. And so we are now piloting that statewide and planning to pilot nationally probably in the next year or so. So really from this kind of early work we did, it became very clear that if we were going to do work that was meaningful, it had to be guided by the voices of the people it impacted, right? Would you agree with that? And so we applied for a Patient-Centered Outcomes Research Institute Award, or also known as PCORI. PCORI loves these projects that are guided by what they call the patient voice. We don't call our families patients because they're not our patients. We call them our parent partners. And so this was an academic, this is a community-wide collaborative that we developed, focused on neonatal abstinence syndrome, and it's really a partnership between academic researchers, clinicians, policymakers, but then at the very heart of this partnership are the families who have been personally impacted by NAS. And the goal was for us to come up with a research and program development agenda for our county. And if you can imagine, when you bring the community in and you engage them, so we had focus groups. We didn't call them that because I don't think anybody would have come. We called it coffee and conversation. And so we had community conversations and just talked about, this is a problem in our community. What do we need to be doing? What are the outcomes that matter to you, and what do you want to see? And boy, let me tell you, when you do that, people will tell you, and then you better follow through. And as you can imagine, it wasn't necessarily the direction we thought we were going. Our parent partners took us in a very different direction and really are at the basis of the work we're doing now, and I'm going to tell you about a couple of those projects in just a minute. These are some of our our parent partners and our community partners. We've had a really great response to this. In Bexar County, we also have a joint county-city opioid task force that was started by our county commissioner and our mayor, and I think that has really given wings to a lot of the work we're currently doing. It really brought everyone to the table because we didn't all know what each other was doing, and so kind of once we all came to the table and shared that information, I think that's when we really started to gain some speed. So one of the things that came out of these community conversations was that women told us, we have no place where we can go to recover with our children. If we need to get treatment, you know, if we're lucky, we have a family member who can take care of our child. If not, our babies are going to go into foster care. And for some women, that was just, I mean, it was terrifying to them. And so that's a huge barrier. And I thought that was really interesting. I didn't do recovery housing. I guess I do now. But at that time, that wasn't my thing. So I kind of went to the literature and I looked at what was there. And what I discovered is that about 70% of women with substance use disorders have dependent children, yet very few, and I've seen some stats as low as 3% of recovery housing offer beds for women and children. So that's a huge gap, right? What I also found is that when women remain with their children while they are accessing treatment services, they tend to continue with those services, complete treatment, and enter long-term recovery at a much better rate. I also found something interesting, and that is that what little research is out there shows that when children are in recovery housing, all of the residents in that facility benefit. I'm a pediatric nurse by trade, so that doesn't surprise me, but I think it really builds a case for the really important role of children in recovery. So as I said, I didn't do recovery housing. I really didn't know anything about it. Lisa Ramirez put me in touch with somebody who knows a lot about it. And I talked to him for several hours, and you know, he started to make me believe that we might be able to do this. Luckily, there are some national experts and some technical assistance that you can get through SAMHSA for free. They had some really great advice for me. They suggested that I try to work with our local housing authority. That would be one of my lessons learned that I would like to share with you all. In theory, that seemed like a great idea. We didn't seem to be getting the progress that we were hoping for. But kind of in the process of all of that, I was introduced to the CEO of a local nonprofit called Crosspoint Incorporated. And Crosspoint in San Antonio offers a variety of social services types of programs to include recovery housing for men and women. It just so happened that they had this beautiful home in our Monte Vista neighborhood, which is in the historic area of San Antonio, that had been providing recovery support services for women, not with children, but just for women. This program had been losing money for about 5 years. Crosspoint was really paying out, just believing that eventually it was going to catch on, and it just never really did. And so they were at the point where they were either going to have to sell this house or think of something else to do. And so I met with Kevin Downey, the CEO, and within an hour we had a plan. And a few months later, we moved our program, Casa Mia, which is state funded. We moved that program into their house, and it's been a partnership ever since. That is probably not a partnership I would have ever expected, but it's really worked out beautifully because Crosspoint has that knowledge that we need about recovery support housing. The School of Nursing brings our expertise in women and children's health. And I think we're really able to enrich the services the women provide. We take our students there. We have a nurse who comes. We have a dietitian. And so we're able to provide parenting classes, breastfeeding classes, women's health types of topics. And so it's really turned out to be a great partnership. I'm not sure we'll have time to play the video. If we do, I will try to show you. There's a little news clip on it. These are some of our families. In the year we've been open, I think the last time I looked, we've got room for 20 at any given time. We've provided services for 40 women and I believe 25 children. We've had many women reunite with their children in the home, which is really incredible to see. We've worked really closely with CPS. That's been a challenge with Child Protective Services. Before I even began this journey, I met with our local CPS supervisors just to talk to them and say, if we did this, what would we need to have in place for you to be comfortable allowing children to stay with their mothers? And so they gave me quite a bit of feedback. It was they needed to have 24-hour-a-day supervision, which we do have. We have 24-hour-a-day staffing and some other things. But unfortunately, by the time we actually got the program up and going, a lot of those individuals had left. And so it's kind of this ongoing, conversation with them. But I think slowly we're making some headway. So after about 6 months of being open, I think kind of once the word got out, we've been at capacity since, which is good in some ways because I feel reassured that women are getting the services that they need. On the other hand, it's incredibly difficult to turn women away who really need these services. And so that's started a greater conversation about what is needed in our community. And so is anybody familiar with the Santa Maria Hostel in Houston? Amazing place. We were just there again on Tuesday. And I've told Nadine Scamp, their CEO, from the very beginning that as soon as I find funding, we're replicating that in San Antonio. And I'm happy to give her credit because it's a great program. For those of you who do not know, it's really a women's campus, and they provide a variety of different programming. We wanted something very similar to that in San Antonio. We may have some different programming kind of based on the need within our community, but we're pretty adamant. And it's been really great working with this nonprofit. They get an idea and they don't quit. So we've kind of been looking at properties, but now I think we're looking at land and thinking about building what it is that we need. We have received word that the state wants to continue to fund this at a higher level, which will allow us to provide other services such as primary care services right on the campus, as well as a newborn opioid withdrawal nursing care facility, which is really exciting. There are only a couple nationwide, 2 that I know of, one in Washington State and one in West Virginia, so this is really exciting for us. We're also very interested in having a jail diversion program similar to the Women Helping Ourselves program in Houston. And then one of the other populations we serve now with Crosspoint is our Esperanza Court. So these are women who are survivors of human trafficking and are in the court system, and this provides them with housing as well. And so probably we will do a phased approach of moving certain one population over to the campus as we build it. But let's see. So I think that kind of the take-home message, hopefully, is collective impact. This didn't happen overnight, and honestly, I don't really think it's been that expensive. Our operating costs for Casa Mia, and we include everything. We include 3 meals a day, diapers, which are incredibly expensive. Really, anything that the women need is under $400,000 a year. And so, if you think about the average cost of foster care for one child, and the downstream effect of trauma that's caused by separation, I think that that's very, very good use of resources. So I think collective impact is important. We talked about legislation. I went and testified for the first time. Last year, I will definitely be doing it again. We have a real champion in the San Antonio area, Representative Ina Minharas, who has really educated herself about NAS and taken a very active role. The reason our NAS symposium will be in June this year is because of her legislation, which passed. We testified in support of that to make June a statewide NAS Awareness Month and really provide quality education so people understand what NAS is, but I think even more importantly, what it's not. There's a real lack of education around that topic. And so I think with that, hopefully we can have time for some questions and maybe some discussion. Thank you.
I'm back. Working with a community-based home visiting program model, you know, there's fear, and understandably why, on the part of the mom who is either pregnant or who has an infant or other children, to disclose that information to a case manager, whether it's a social worker or a nurse, because of the ramifications of it, the legal ramifications of it. And so I know you said that, you know, that whole turnover rate situation with CPS, but what were some of those initial conversations like with the supervisor that you were able to have some of those conversations with? Because, you know, I'm a social worker. This is that gray area. It's like it's not an illegal drug, but it can certainly cause long-term negative effects to an unborn child. But it can also just interfere with an individual's ability to care for other children that they do have. So it's like, okay, what do we do? Because I'm from Houston in Harris County. We are in the process of enrolling and providing case management services to women. It's going to come up.
Right, and so to answer your question, when I initially met with the supervisors, they were very, very supportive. And the kind of the take-home message was, you know, their ideal case scenario would be a woman becomes pregnant, or discovers she's pregnant, you know, gets into a medication-assisted treatment program, moves into a facility like Casa Mia, is stable during her pregnancy, delivers, and then comes back with the baby. We've actually had that scenario once of all of our moms. That's happened once, and actually a CPS case was not even opened. So that was really exciting, but I can tell you that's not the typical scenario. And I think from my own personal experience, I think that the message doesn't always trickle down to the caseworkers, because we've had some who are absolutely fabulous, and we have a completely open door policy. Their CPS workers are welcome to come and tour, see the facility. They can come if they need to do supervised visits, they can do that. We've had dads come and do supervised visits. But I don't, and moms have told me this for years, it all depends on who your caseworker is. And you know, I've thought a lot about what can we do other than educating? You know, what can we do to have more consistency, maybe more oversight? Because I've been to court quite a few times this past year. I'd never been to court in my life, but I've been to court, 3 times in support of some of our ladies who are trying to get custody of their children back. And I don't really have an answer on how do we fix that, but I think about it a lot.
Yeah, or just how to approach it and ensuring that we are complying with our duty to report, but also, wanting to educate the mother, the family about, because they may not be knowledgeable of about what long-term effect it can have on, an unborn child, or just how it's impacting their life. They may not even realize it. So there's, room for education at a lot of different levels. But as we're enrolling families, we've had some conversation about it. We will certainly be at the conference at the end of June in Houston. But yeah, I don't know if there's anyone in the room from the Texas Department of Protective and Regulatory Services. It's a mouthful. But yeah, if someone is.
You mentioned something, you mentioned education, which I think is so important, but I think educating on the facts that we do know. We do not have good long-term data on what does happen during prenatal exposure to opioids. For those of you who may be old enough to remember the crack cocaine epidemic of the 80s, there was mass hysteria around prenatal cocaine exposure. And, after 30, 40 years of long-term follow-up, there really is, there's no evidence to show that the children who were prenatally cocaine exposed look any different than other children who were raised in their same environment, their same community. And so I really like to think of this as a social determinants of health. There's a lot going on for some of these families. They're dealing with food insecurity, housing insecurity, violence in their neighborhood. So how do we, as a community, a society, start to address some of those issues? Which we know, the young brain is very, has great plasticity. And having a nurturing, caring environment to grow up in where you're not hungry makes a huge difference. And we know that. We know that. We have evidence to show that.
Did you all have conversations with any of the healthcare systems where these moms were delivering?
We do. We have better luck in some hospitals than others. We have some hospitals that are just doing amazing work. Really amazing. One in particular is our Downtown Baptist. They've got a Koalas program, which is really great. The Mommies program, most of our ladies from the Mommies program deliver at University Hospital. But yeah, there's a lot of work to be done. I will tell you one thing that I think is really exciting. The first NAS symposium we had, I felt like it was a lot of, well, what do you do with these ladies? Kind of that kind of conversation was, they just, all of this, I don't know what it was, but this last NAS symposium we had, there wasn't any of that anymore. It was okay, what do we do about this? Which to me is super exciting. It wasn't this blaming or, vilifying women anymore. It was, okay, this is a problem, how do we fix it? And so we've completely changed our agenda for this year. It's going to be very hands-on. We're going to do simulation, and we're going to, it's people, I think, at least the ones who are coming to the NAS Symposium are ready to make changes in their facilities. That's exciting to me.
Thank you very much.
You're welcome.
Hi.
Hi.
Dr. Cleveland, it's good to talk to you again. When we were working with you guys on some of the collaborative work you're doing in San Antonio, a lot of things that came up, and Dr. Eppes, I'm going to let you jump in on this one too. This interaction when you have a woman who has substance use disorder walking into an OB's office, and that education to the OB and that education to that provider and transferring that education into the delivery hospital, how have you guys started to address it? Because that was one of our things that we identified was a huge barrier.
Well, I know that Texas is now rolling out the AIM opioid bundle, which I worked on at the national level, which is really exciting. And I know it's not one of the mandatory ones, but I believe UHS is participating in that. So I'm hoping that's going to bring greater education and awareness for those OBs who are in the hospital. I'm not sure how we reach private practice obstetricians. And I was at a meeting the other day and somebody said, where are our obstetricians? Our pediatricians seem to be really getting on board. But I don't know. If somebody has ideas of how do we better engage some of our obstetricians, I would love to hear those, because we've had that challenge as well.
I was just going to add to your question about the communication between delivery provider and delivery hospital and postpartum and CPS. I think just yesterday on our opioid call, they were presenting that our state is kind of piloting this new plan of safe care concept, which would try to facilitate that communication throughout those places, and DFPS is actively involved with working on that in different areas. So isn't a solution, but is the beginning to something. While you're making your way to the mic, I was going to ask, since we do have now 10 hospitals piloting the opioid bundle, there are a lot of folks now trying to do similar work and build communities and collaborations. What advice would you give them?
I think just be persistent and don't give up. I often feel like what I lack in brilliance, I make up for in just being stubborn, because it can, it can be a real challenge, and it's very time consuming, and you have to be willing to put in the time. When you're building those community partnerships, you have to be sincere, and you have to build that rapport and that trust, and that really takes time. But with that said, I also think that when you're trying to partner with somebody and you're not getting anywhere, it's okay to move on. And that was a lesson that I learned, because I think when you find those partners you're supposed to be working with, things just click. Like when Kevin Downey and I met, literally within an hour, we were rolling. After 10 months of trying to get this project up and off of the ground. So I think, reach out and don't get discouraged. If you don't find the right person the first time, keep looking. Eventually you will. But it's really those partnerships and those collaborations that are what are going to help us, build these wraparound types of programs that I think our families really need.
So my question focuses on facilities, specifically hospitals, that will be receiving these mothers who may not have as much experience with opioid disorders, Suboxone treatments, methadone treatments, and the modalities, the typical practice regulations and standards that those mothers are held to. Is there an education piece or a training piece that's basic and introductory that we can do in the meantime as we're working towards these bundles and collaborations, that we can roll out to at least have a foundation in preparation for receiving more of these patients over time?
Yeah, I think there are some great resources now. I don't think that there probably were 5 years ago when we first developed the Mommy's Toolkit, which is a resource. Again, it needs to be updated, but it is a resource. It's also available in 4 online learning modules that we are also going to be updating and trying to make a little more interactive. They're kind of boring right now. So we're going to be working on that. But there are other great resources. One in particular that I always think of is Ohio Moms. And if you just Google it, they have an incredible website with like different tracks where if you're a patient, if you're a stakeholder, if you're a care provider, and kind of all of those things that could help you where you're at. So that's a great resource. I came across another really great toolkit that was recently published in Neonatal Network, which is a great journal, but it's not widely read. And so it's called the ACTS script, and it's just a beautiful script for stigma, for addressing stigma in the healthcare environment without having a huge confrontation. And I'd be happy to send that to you if I'll give you my card. But one of the things our students have are running into is, we do a lot of education with our undergrads. Undergrads can be kind of judgy. I don't know if any of you all know that, but they can be, and which surprises me. So we've done a lot of work with our undergrads about substance use in general, and then in this population in particular, and I feel like we're making some real strides with them, but then what happens is they go to their clinical experience in the hospital and they hear providers, drug babies, methadone moms, all of that stigmatizing language, and they're just stuck. They're like, what do we do? And so this ACT script, it tells you exactly like, how do you address that? How do you change that conversation, turn it more positive, and then sort of learn from it. So, and I can't remember what I think it stands for, I won't get this right. Acknowledge, create an opportunity for reflection, I think. And then I'll send it to you. It's really great. And I could absolutely see our students being able to use it without getting into trouble. But still like just chipping away at that culture that has become accepted, and it's not acceptable.
Thank you so much.
You're welcome. have just one piece of news that I think is really good news that I'd like to share with y'all. So we've focused a lot on opioids. How many of you have problems in your communities other than opioids? Right, I know, and that's been a problem from the very beginning with these state opioid response dollars. And so we've gotten word recently, I think because people are demanding it, that these restrictions on those dollars be relaxed so that other types of substance use can be addressed. We're now saying that stimulants are the fourth wave of this crisis. We're seeing a huge uptick in methamphetamine and cocaine use. So I think, to me, that's very encouraging, and I think maybe it allows us to have a broader conversation about mental and behavioral health and addiction. But thank you.
Thank you so much.